everyone, welcome back to another episode of CHD Unpacked, a podcast about living with congenital heart disease. This podcast is brought to you by the Canadian Congenital Heart Alliance. I'm your host, Amanda, and today we'll be unpacking the topic of congenital heart disease and sexual health. We're very excited to be joined by today's guest, Dr. Lorna Swan. Dr. Lorna Swan is a clinical lead and consultant cardiologist. In 2020, Dr. Swan joined the Scottish Adult Congenital Cardiac Service at the Golden Jubilee Hospital in Glasgow, after working for 15 years in London and Toronto. Lorna completed her cardiology training and MD thesis in Glasgow. She then took up an ACHD consultant position at the Royal Brompton Hospital in 2006. She was the program director for 8 years. In 2018, she moved to the Toronto Adult Congenital Program. During her time in Toronto, Lorna's clinical and academic remit included ACHD, cardio-obstetrics, and transition. In recent years, Lorna's teaching and academic output has mainly been related to ACHD heart failure and cardio-obstetric guidelines, working with the IS-ACHD, the ESC, and the Canadian Society for Cardiology. Please join me in welcoming Dr. Lorna Swan. Hi, Dr. Swan. Welcome to CHD Unpacked. Thank you so much for joining us today.
Thank you for inviting me.
So just to start off, we'll be talking about congenital heart disease and sexual health today. Can you tell us a little bit about the scope of your practice?
Yeah, so for many years, I've been an ACHD cardiologist, so mainly working in the UK. I've also worked in Canada. So my practice is solely ACHD. I don't do any general cardiology, so a lot of pregnancy and heart disease work.
Okay, great. And can you just give us a brief overview of why you feel that sexual health is important and how it impacts other aspects of one's physical and mental health?
So being honest, it wasn't something I had really thought much about, and there was really a couple of conversations with patients that made me think, actually, this is something we don't really discuss very often. And it was two completely different patients. So one, an older patient who was in his kind of late 50s, who we had a kind of discussion about sexual health, and the opposite, a teenage patient. So although I spend a lot of time talking about pregnancy and contraception, sexual health wasn't something we really mentioned. And in retrospect, you think, wow, that's such a big part of people's lives that we are kind of ignoring.
Mm-hmm. And given that it's so important, why do you think that it's not routinely discussed in follow-up appointments?
So I think a lot of reasons. I think none of us feel we're experts. It's not something we ever really get any training about as cardiologists. We hardly get any training about things like pregnancy, so we really don't get any training about sexual health, apart from some of the drugs we prescribe can give erectile dysfunction. That's about as far as our training goes. And I think, and again, it might be different in different cultures, but I think just pure embarrassment is a reason often that people don't want those awkward or slightly clumsy conversations.
And do you think that some patients shy away from those conversations, or can you tell that some might want to bring that up a little bit more in follow-up appointments?
So I think again, there is some innate embarrassment on both sides in terms of patient, in terms of the healthcare provider. I think sometimes for many folk, it's a relief when you bring it up, because it may have been something that actually they were struggling with, or they were worried about or concerned with. And just to have that opportunity to bring up an issue, whatever the issue is, you see almost sort of weight fall off the shoulders sometimes when they think, oh, well, I actually can talk about this. This is something that's causing some problems.
Yeah. And I think as soon as that initial conversation happens, it's kind of the gateways are open to then have those conversations in the future, because they understand that it's a safe space to have those kinds of discussions.
Yeah, and I think that takes time. I think it's not the kind of thing you'll maybe talk to your provider the first time you meet them.
For sure. Yeah.
And I don't know, again, practice varies in different countries, but very, very often when we're seeing patients, particularly patients who have maybe had quite a challenging time, we often see them with their spouses or their partners,
Mhm.
and you can see how much their illness or whatever they're going through impacts on them as a couple,
Yeah.
or say, or the wider family. So you can see how important it is to talk about sex and relationships with them.
Mhm. And when you do have these conversations, can you speak to the level of health literacy or understanding that the adult congenital heart disease population has as it pertains to sexual health, both in like a general sense and in terms of factors that might impact their congenital heart disease?
Yeah, so there's a little bit of research in this, and interestingly, so they asked women
Mhm.
about, so with women with congenital heart disease, how did you feel, what was your knowledge of sexual health and sexual well-being in relation to your heart? And they gave themselves a score of 3 out of 10.
Wow.
So I think the baseline level of understanding is fairly low.
Mhm.
Um, I mean, people probably know about one or two drugs that potentially can lead to things like erectile dysfunction, but I don't think there's any much knowledge further than that, and definitely not much understanding of some of the psychological components of living with a congenital heart disease.
Mhm. Can you speak to some of those psychological components and how that might impact someone's confidence in their sexuality or their maybe willingness to explore that?
Yeah, so this is something so a group of us recently looked at this, and we wrote about this in quite a lot of detail, and we had the advantage of having a psychologist as part of the team who was also an ACHD patient.
Mm.
So some of it was things that I had thought about before. So some of it was things like body image, living with scars, when to disclose your congenital heart disease to like a new partner.
Yeah.
But some of it was fairly eye-opening. So quite a lot about just the impact of medical trauma and just experiences of being a child who's gone through maybe several procedures when they've been young, and how that impacts on people's feelings of safety and also some of their feelings of sort of their own bodily autonomy. So there's a whole range of issues that came up in terms of the psychological component of all of this.
Mhm. And are there physical factors related to someone's CHD that could impact their sexual function? Like, for example,
Yeah,
that might
yeah.
not
So
stamina in terms of physical activity.
yeah, so it completely depends how well you are. So for most patients, there isn't any physical issue. If
Mhm.
you're thinking more of the patients who, or the people who are at the kind of complex end of the congenital heart disease spectrum, or those who are starting to live with complications like arrhythmias or heart failure, there's definitely a kind of stamina well-being component of it, sort of a physical fitness component of it. But that's really only important for patients who are, or people, keep calling patients, people who have more complex disease. For many folk, they're active and fit and well.
Okay. And in terms of the psychological factors, you talked a little bit about self-image and trauma. Um, do you find that this is something that's very prevalent, or do we kind of need a little bit more research to understand just how prevalent these issues?
Yeah, yeah. So we have quite good data on things like anxiety, depression, and a bit of data about things like PTSD.
Mhm.
Um, I think things that are understudied in terms of the literature are some of the impact on young people.
Okay.
So I think we've traditionally looked at things like scars and said, okay, there's some issue around self-image. But speaking to patients, and particularly to young boys, there's quite a lot of issues around things like being smaller than average in terms of height, which some of our patients are, not being able to put on muscle, having a slim physique. Some of these more subtle parts of body image that I think traditionally we've thought more of the girls, and we've thought more of the scars, whereas these other components are also kind of just under the surface if you start to scratch and just kind of ask people. And it always shocks me when I deal with adults, when you start to talk to adults who've got congenital heart disease, how many of them had bad experiences of being bullied or bad experiences at school. And some of those early interactions with people really colour their ability to form relationships later on.
Yeah, I agree. And I think the piece that you're mentioning about body image as it pertains to boys growing up, I think there's a lot of emphasis on, being strong and, not talking about the things that bother you. And I think that kind of masks a lot of the difficulties that they might experience. I think self-image and body image are very prevalent issues in terms of little girls growing up, but at the same time, that is also given more attention, I think, by society. And I think that, the body image and physique that, biological males are expected to attain as it, pertains to society's standards, that kind of pressure to achieve that is often overlooked. And I think that it might suffer a lot in terms of trying to deal with that.
I think it changes as well. I think there's also a kind of a fashion component of what's expected now is maybe different than 20 years ago, but now there's definitely a lot of people lifting weights and people kind of bulking up and people wanting to take protein. And for your kind of teenage patient, I can think of one boy who talked to me really honestly about this. He had hypoplastic left heart syndrome, and he really struggled to put on any kind of muscle. He looked several years younger than his biological age, and he really struggled that he was not as tall as his peers, not as kind of manly as his peers. And I think those kind of things are really, really important.
Mm-hmm. And I think just bringing up the conversation and, making people feel seen and understood in terms of the struggles that they might be going through. Obviously, you can't fully relate to what someone's feeling, but at least just having the conversation, I think, is really important. I also just wanted to ask about, for those that have CHD that are also a part of the trans community, are there any considerations that need to be made before they take any hormones as a part of their transition?
So that's it's obviously a small population, and I'm not an expert. I think the most important things are to not ever make any assumptions about somebody and about what they want, and to try and be as helpful and as open as possible.
Mm-hmm.
I mean, I think we're all aware of literature around the trans community of how the kind of rate of suicide can be elevated, often when people find that they are not finding people who will advocate for them or people who are open to listen.
Mm-hmm.
And I think as a cardiologist, it's my job to try and be as supportive and helpful as possible. It's easy for me to say, no, you can't take estrogens, or no, you can't have this treatment. But if this is potentially life-changing treatment and is massively psychologically important for somebody's well-being, I think it becomes a balance of risk of sitting in the room with people who are experts and coming up with the right answer. I mean, in general, transition when it is transitioning to male is easier in terms of treatment, like testosterone and other drugs don't appear to have much in the way of cardiovascular complications, although we don't know some of the long-term issues. Mm-hmm. The big challenge in cardiology is when we're talking about patients taking estrogens or anti-androgens in terms of things like risks of clotting and thrombosis. But I think it just needs to be being part of a team that's helping support the patient. And also, you really want the person in front of you to feel that you're on their side.
Yeah.
And that you're going to try your best. Now, the answer might eventually be, actually, this is quite a risky thing that you want to do.
Mhm.
It might be me saying, in my cardiology opinion, I'm worried about some of the complications, but I think it has to be, I'm on your side and I'm trying to be helpful. And also, I'm trying to be educated as well because I'm not an expert. This isn't something that I deal with every day, but I have a duty to learn from the person sitting in front of me as well.
For sure. And I think you're in a great position as an ACHD cardiologist because there is that longevity of a relationship and that continuity of care that someone may get with their family doctor as well. Like that relationship also has that component. But I think just having that tight relationship throughout the years and being so closely related to a very personal part of somebody's health kind of puts you and other adult congenital heart disease specialists in a very special position to then have those conversations with people about their sexuality too.
You're often a gatekeeper to other services. And also, again, keep saying practice varies in different countries. But for example, where I work, often people are scared of ACHD patients and they won't do anything without, you need to speak to your cardiologist. You need to check with your cardiologist, which is good, but it does mean that we are then in a position to be a gatekeeper, to help refer somebody on to experts, to signpost them to other organizations and other people that can help them.
Mm-hmm. Mm-hmm. And do you find that becomes challenging sometimes to navigate all the different aspects of someone's care?
I think not usually. So I think usually it's a privilege, to be honest, to be the person that is somebody's first point of contact. So in my current unit, we also have a team of specialist nurses, and the specialist nurses are absolutely the patient's first point of contact for almost anything. And I think they feel trust. There's a lot of trust, obviously, in the care of someone when they have a kind of more complex lesion or more complex past medical history. And I think patients will often come to their nurse specialist or to their cardiologist because you know the history, you know the last 20 years, you've been with them and through their last 3 operations or last admission or whatever. So I think that gatekeeping role is a really important part of what we do.
Mm-hmm. Yeah, I agree. I'm wondering, as a person that is then being the gatekeeper for all of these services and someone that the person with CHD is turning to talk about all of these things that they're going through, do you have any advice for someone with ACHD who's struggling with their sexuality or struggling with their sexual health, having some psychological difficulties kind of navigating what to do moving forward?
So it's trying to be brave, isn't it? It's trying to be brave and to reach out, even just in a very kind of non-specific way, to your ACHD provider. Now, you might find that difficult. It might be that you want to send an email and just say, look, I want to talk about this next time I'm here. I will find it hard to bring this up. Could you bring it up for me? I find our specialist nurses are, I think, easier to talk to than maybe the cardiologist, who might be kind of a little bit more intimidating or a little bit kind of more remote in terms of age, for example. So I think if you've got specialist nurses or other people as part of your local service, that can be really helpful. But also there's a responsibility on the cardiologist and us to be proactively asking people anything else you're worried about. And it can be very gentle. It can be, yeah, are you in a relationship at the moment? How is that relationship going? I mean, what's your plans for the future? So there can be subtle ways into those conversations that are not too threatening.
Okay. Yeah. And so you kind of wait maybe a couple times after meeting the patient to introduce those kinds of conversations yourself if they haven't like done so before?
So one of the other things I spend some time doing is some advanced care planning for people who are kind of more sick. And there's a sort of a 3-date rule in that
Oh,
you
okay.
shouldn't really talk about these things till the 3rd date. So the 3rd time you've met a patient. And I think that's probably true for this. I think it needs to be someone who you've started to have a little bit of a rapport and a bit of a relationship with before you dig into some of these slightly more difficult conversations. For some people, again, it's a generational thing. So for some folk are very open and very matter of fact about how they talk about things. It's just part of their normal life. So again, it's about coming without any kind of preconceived ideas or kind of expectations.
Mm-hmm. Okay. And if someone were to open up to you about those struggles, do you often connect them with any like psychotherapy resources or other different allied healthcare workers to address some of these things that might be more related to trauma or anxiety or just past difficult experiences that they've had?
Yeah, completely. So the first thing to acknowledge is to me. I'm not an expert. And I think for me to dabble in a little bit of kind of armchair psychology with somebody is completely not fair. I'm not trained, particularly if you're talking about people who may have had history of trauma or abuse or other things in the past. And equally, I'm not a gynecologist, I'm not an endocrinologist. So it's about signposting people to the right services. It might be that the patient needs a referral on to a gynecologist or a urologist. So yeah, so a lot of it is just about helping access care.
And if someone wants to maybe read up about certain pieces of information or would just like to kind of educate themselves on their own before they have a conversation in person with their cardiologist, do you have any resources that you could maybe point them towards online that they can access?
Yeah, so we wrote, as a group, we recently wrote a paper in JACC Advances. So if you just Google JACC Advances, Sexual Wellbeing, ACHD, you'll find that paper. And then there's a table of some online resources. So, and there's also in there things like a book that was written by a patient, again, just talking about some of her issues with past trauma and issues. Yeah, but again, say there's lots of useful online resources, and most ACHD centres will have their own website with some useful resources as well.
Okay.
So just reach out and ask.
Okay. That sounds great. Well, thank you so much, Dr. Swan, for joining us today and for providing your insight on this very important topic. We really appreciate you.
Thank you again.
Okay, take care.